So let's see, this is a complex LAD and left circumflex PCI. The next slide, please. So this is 72 years old, presented with chest pain and palpitation. He suffered from hypertension and dyslipidemia. Next. On the ACG is on the normal sinus rhythm with the right bundle branch block, with the first degree also of AB block with 220 milliseconds on the PQ extension with frequent supraventricular and ventricular extrasystoles. The blood tests are normal on the basic blood test. The echo Doppler evaluation showed the preserved left ventricular ejection fraction with the 62%, with some hypertrophy. On the 24 hours Holter monitoring, there's going to be some extra bit that I will show you in the next slide. On the stress echo, he presented angina and also a significant ST depression at the maximum effort. So that's why the stress test was stopped with a significant hypokinesis on all the anterior and anterolateral wall. Next. So this is the ACG with all the findings I have already described with this first degree AB block and the right bundle branch block. Next. This is the Holter, the ambulatory Holter monitoring with some extrasystole bimorpher with some doublets and triplets of the extra bits during this evaluation. Next. So for all that reason, this patient was considered as a high risk for ischemic disease, considering that he was symptomatic with arrhythmia, with the changes on the ACG, sorry, and with a significantly positive stress test. So the patient was referred for angiography. This is the big right coronary artery with diffuse disease, but not significant stenosis in our consideration. Next. And here we observe an epicranial view without significant stenosis on the right, but with significant calcification. And on the right side of the panel, you can observe a very tight stenosis on the left circumflex and a very significant stenosis on the proximal LAD, where it's a bifurcation with 1 or 2 diagonal branches. Next. There you can observe calcification, tortuosity, and tight stenosis on the proximal LAD in both projections, epicranial and LAO cranial. Next. This is the spider view. Once again, this is a very tight stenosis on the proximal LAD, and then the bifurcation after the stenosis with these 2 diagonal branches. And on the right of the panel, you can see right cranial and oblique inclination, where we can observe a little bit much better this very significant and calcified and tortuous proximal stenosis on the LAD. And the indication, in our opinion, considering the proximal stenosis of the LAD, 2-vessel disease in a symptomatic patient, the indication of PCI, or actually the revascularization, is appropriate in this patient, although it's a chronic coronary artery disease, unstable. At the end of the heart team discussion, CABG was considered probably the best indication for this patient, but he refused surgery and he chose to undergo PCI. We agree on that this is an acceptable indication, probably not the best, but it's a good indication if we can treat this proximal LAD and then the left circumflex, and then we put the patient on optimal medical therapy and we keep a very, close follow-up to see how is the evolution during the time. Next. So we have prepared for radial access. Dr. Carlos did the radial access. We are going to predilate and to put stenting on the proximal LAD, and we will try to be provisional. So let's move to the lab. You can share the monitor views. We are going to advance the guiding. This is not the guiding I like the most, but this is the guiding that we have. So here we can observe the calcium. We are dealing with a lot of calcifications today. So we are going to use the regular BMW wire. We are going to cross this lesion, and then we will decide whether to do IVUS or to predilate and then to put a stent and to do IVUS to have a better decision about the final outcome. We are going to use broad med balloons from China. They have FDA approval. The Artemis balloon, we can use a 2.5 Artemis 0.20, 2.0 by 20. So with the using this balloon, which is a low profile balloon, is one of the lowest profile, is 0.016. We have diameter from 10 to 4 and length from 5 to 30 millimeters. This is a compliant balloon, very low profile. It's good for helping to cross and to predilatation. Then we have other balloons for non-compliance that we are going to use afterwards. So for sure, this tortuosity is going to be a problem. It's something that we predicted because we have the tortuosity and the calcium. We discussed the possibility of doing rotablator, Rotapro, but there's a lot of tortuosity there. I scare a little bit to damage the middle segment on the diagonal after the first bend of the vessel. So to be honest, I don't like to use it in this situation. Inflate, Carlos, let's go, volver. Deflate. So the profile of the balloon was okay. And this is the maneuver we use to advance Godzilla when we had to go for a deep intubation in flying. Okay, deflate. I think it's not gonna be easy to advance the IVUS. Try again. Okay, deflate. We will try. If not, we are going back to the balloon to advance the guiding, deploy the stent, and then we control the stent.
Yes, we are the middle segment of the LAD, isn't it?
Yes, yes, absolutely.
We can see an eccentric plaque, a mild eccentric plaque, 5 to 8, then a severe plaque with a severe calcification, superficial and deep calcification. This is a bifurcation.
And this is the proximal LAD.
The proximal LAD was also
the tightest stenosis there. Calcified.
Yes.
Okay.
We have a very calcified lesion.
And then it's going to be, this is the
left main and the ostium. Yes, with a mild stenosis.
Okay, great.
So we are going to first see the reference diameter. It is. So
I think here, after, while Gustavo is preparing the measurements, we had to decide what to do. Let me tell you what I could do. First, I'm gonna pre-dilate on this curve, which is proximal to the reference segment that Gustavo showed on the IVUS with only middle plaque. So we have there a 2.5 diameters on the vessel, probably 3, with a tight and concentric calcification. So there, we can use an Apollo non-compliant device, 2.5 by 20 or something like this. This is a non-compliant device from Brosmed. This is only 3% axial growth when you inflate at very high pressure. The average burst pressure is 30 atmospheres. The diameters that we have is from 2.0 up to 5 and the length from 6 until 30. So we are going to use 2.5 by
20.
by 20.
20.
Okay. So I'm gonna go distally. Then I'm gonna use, if I have a 3.0 cutting balloon for the proximal calcified lesion, and then I'm gonna deploy the stent with the help of the telescope device. We can inflate there. We have the tight calcification, a 3.0 cutting balloon. Let me add, ¿tenés el 3.0? Okay, so let's leave the balloon there. I'm gonna advance the telescope device. So because the profile of the cutting balloon is absolutely worse than these balloons. Wait a minute, Carlos. Deflate. Okay, which stent would you use, Gustavo? 3.5 or 4?
3.5.
Okay, give me a 3.5 by 24. That's okay. So I use the balloon from the stent as a support, a protection to advance the guide extension so that I have a perfect position in there. So it's going to be easier to advance the 3.5 stent into this curve. That's could have been difficult with this guide support, which is actually very weak.
I think that the 3.5 will give you a better navigation inside the vessel, and then you can go up to 3.9 through 3.8.
Absolutely, which is
And
absolutely. So something that we are not doing here, but because I felt that it advanced very smoothly, is to check when the stent is entering into the proximal part of the guide extension. So I will leave the stent distally, sorry. I will pull the device. I will do a test to be sure which is going to be the position for deployment. So we are quite far away. Have to go back, test. And now we can go to spider view. We have a lot of small branches. Then we will decide which one we should rescue, test. There is a huge diagonal there that hopefully is not going to be compromised, because with the guide extension, I cannot use two wires. Test, Carlos? This is one limitation of the guide extensions. So probably I have to go a little bit further. Test again. Sorry, again. Oh, again. Okay, I feel better there. Okay, inflate. 1, 2, 3, 4, 5, 6. So as you can observe, the diagonal is perfect with an absolutely normal flow. I don't think so. We have to go for a kissing balloon there.
No.
What I would do is IVUS on the LAD to see if I need post dilatation there.
so,
You can describe, Gustavo.
so this is the middle segment of the LED, isn't it? Yes, this is the stent. It has a very good position and a good expansion.
We have to see how the circuit is and how fast we can go, but I think it's nothing special about the circ. Probably the more complex lesion was this proximal LAD lesion with such calcification, tortuosity, bifurcations near the ostium, and so on. Excellent, excellent. You see the expansion of the stent, I think it's acceptable. We have a little under expansion where we have the curve, but I would accept this outcome. So let's go to the caudal. Vamos a la caudal.
Caudal.
And I will see if I can do the circ in 10 minutes. I don't know. Oh, it's so tight and so short the distance I have to cross. The problem is Okay, let's change the wire. Let's change everything. Take the balloon out. Give me a micro catheter. Un Corsero, Caravelle, whatever. ¿Tenés ahí?
Sí, acá está. Here is.
Okay, perfect. We have only 5 minutes. I think the important is just crossing and then the procedure is going to be done. So we are using the Caravelle because it was available, nothing special about that. Hold the wire when you have it.
Listo. Okay. I hold the wire.
No tires, no tires, no tires, no tires. Contala. Poneme un poco de zoom, please. Okay, better. Give me the cyan blue. You see that the backup of the catheter is awful. Acaba. Y búscame una crossit. Sí. Which is the remaining time? ¿Cuánto tiempo? Okay, 5.
5
Okay.
minutes. Acá.
Andres, any question or comment from the audience? Any suggestion?
Yes. Would tremor accent instead of
Sure, absolutely. Guiding support would have been much better from femoral access, no doubt, in this case. But when we finish, the patient is going to be more comfortable, less risk of bleeding, and all the benefits of the radial access. This is the issue. We are uncomfortable, but the patient is going to be better. Test. Sorry. Okay, test. Oh. Give me the crossit. No, cyan blue is not working. Need a very small bend on the tip. Okay, according to Claudio's watch, we only have 1 minute. Whatever the transmission is finished, we are more than thank you to all of you for helping, for supporting, for watching, for comment, and for everything. I think the case is going to take a few more minutes because we need to cross this tight stenosis. And you know, it's always a matter of time. Crossing. Yes. Thank you so much.